Good afternoon. So Nemours is a children's health system that has taken on the challenge of integrating population health and clinical care. We've done that in two ways that I'm going to talk about today. Here we go. The first is starting from the community. What we did was, rather than focus on our own patients, we really took a broader approach. We looked at the whole state of Delaware and really thought about how can we care for and help children throughout the state grow up healthy. And so rather than just focusing on our 50,000 patients, we were now expanding our care to 230,000 children in Delaware, and really thinking about it from the community perspective and from the system's perspective first. In addition, we also start from the clinical approach too, where we've looked at our patients with asthma, and then we've looked at the community factors that affect their health. And so that's another approach, the one I call the outside-in approach and one I call the inside-out approach. In both of these cases, we've really thought about spread, scale, and sustainability. And certainly the Affordable Care Act creates opportunities for both of these types of population health approaches. I'm going to talk more as I go through these examples about how you go from the local and state to think about spread and scale and sustainability, and ultimately to think about spread, scale, and sustainability nationwide. So a little bit about Nemours. First, we're a nonprofit organization, an operating foundation dedicated to children's health and health care. And we offer a full continuum of clinical care, research advocacy, education, and prevention programs. And nationally, while we operate in the Delaware and Florida area, nationally our goal is to improve child health and well-being by leveraging our clinical and population health expertise. As I mentioned earlier, we have two children's hospitals and obviously primary care and subspecialty care. But we also have a unit that I started in 2004 that is solely dedicated to population health. So the next two slides I'm going to go I'm sure you've talked about this earlier today, but these were what motivated Nemours, that was primarily a clinical focus prior to 2004, to expand our mission. And I believe that folks have probably gone through the major determinants of health and the high costs. We also, this is from the California Endowment, and I think what really ultimately got us to think differently was that place matters. Where you live and how you live in the community makes a difference in your overall health. So we expanded our approach to focus from a focus just on medical care to a more multifaceted approach. And then from a focus more on acute illness to prevention and chronic disease population health. And very importantly, rather than just to focus on the individual, we really started thinking about population health and geographic populations and the community. And in that, really started focusing much more on prevention and focusing on health and wellness in addition to disease. And so this is our basic model, is really connecting the community piece and the health system piece. And we really offer a continuum of care and services to support a child growing up healthy. And I'll go through this as I go through my talk. So let me start with the different case studies. The first thing I'm going to talk about is our obesity prevention work in Delaware, and then talk about how we took a piece of that and really thought intentionally about how to spread and scale that nationally. And then also talk about our most recent award from CMMI, our Innovation Award, where we're really integrating what's happening in primary care for children around asthma to what's happening in the community. So in terms of the basic elements of our approach in Delaware, we really started with defining our outcomes for the community. And so we had our goal was to reduce the prevalence of child obesity for children between the ages of 2 and 17 by 2015. And to do that, we created a multi-sector approach where we go to all the places where children spend time to really have those systems of care work together to support a child's overall health and well-being. And so that meant engaging schools, child care, primary care, and the built environment, other community organizations in a statewide effort to really improve obesity in our state. We learned early on that we needed to take an approach that included both policy change, getting at that systems change, as well as practice change. Because you can have the best policy in the world, but if people don't have the tools to implement it, or they don't know how to implement it, it's not going to be implemented. So we really came up with a set of high-priority policies and practices to support a child's healthy activity and healthy eating. The other thing that we did was we had a social marketing campaign. So we kind of had a push strategy, and we also had a pull strategy, where we were, we went and had a social marketing campaign to really try to create the demand for what we were trying to do. And the two other parts of our strategy was, number one, to leverage technology, and number two, I wanted to make the point about, in a way, we served as an integrator, or the backbone organization, the convener, but we really worked intentionally and systematically across these sectors, working, of course, in partnership with many, many community partners to improve health and well-being. And Nemours has written a lot about the concept of an integrator, a quarterback, whatever you want to call it, we are, the paper on that is in the site here. But this is kind of how it looks as an integrator. You're really trying to develop a common agenda, you're engaging leadership and partners, you're focusing on spread, scale, and sustainability, and you're focusing on continuous learning and improvement to promote population-level solutions and changes and improving health. And these are all the different types of community partners that we work with. So as a result of all this work, we went statewide in 2006, and so we just released our third iteration of our Delaware Survey of Children's Health. I do want to thank the Robert Woods Johnson Foundation for their support to help us in part with our evaluation. We have seen that the rates of obesity and overweight have leveled off in these last 7 years, and we also found that overweight and obesity decreased among African American males and white females. And this finding was supported by behavior change. We saw an increase in the amounts of fruits and vegetables that children ate a day. We saw declines in the consumption of sugar, sweetened beverages. We also saw an overall increase in physical activity. And all of these things, as you know, there's a science that links this to reducing overweight and obesity. And sadly, the one area we've actually seen increases on is actually screen time. So we know that there's more work to be done in this area. Now, as a part of this, we also, as I mentioned earlier, worked in different sectors. So we worked in schools, where we piloted 150 minutes of physical activity. And we actually found that the students, were 1.5 times more likely to achieve an indicator of physical fitness than students in the control group. And now we have recent data that actually shows that there's a relationship between fitness and academic achievement. Because as Dr. Shortell said, he made the point that when you're working in partnership, you have to understand what the other partner's agenda is. And when you're working with schools, their number one agenda is test scores and improving academic achievement. And so when we were working with the schools, we really had to make the case that healthy eating and physical activity are directly related to school performance, and that was our way of being able to engage them in the work. We also work in child care, and as I mentioned earlier, we have a system of both policy and practice changes. And so we have a collaborative method that we have in child care, and our results showed that 100% of participants had made significant changes in healthy eating and physical activity. And 81 made significant changes actually in both. And we did a lot, because we are a clinical operation. We, in primary care, did a lot of work where we created a new smart set in our EMR that has lifestyle counseling, and we found that 95, we worked to make sure that our primary care doctors and patients were using that, and you can see that actually increased from a low rate of like 30 or 40 when we first started to 95%. So then I want to take child care and zoom in on child care and talk about how we've worked now, because one of the things I talked about earlier is I think there needs to be intentionality about taking the the lessons learned at the local level, and using that to inform what's happening nationally and using it to spread and scale. And the way we did that was to focus in on this area of child care where we had a model program that was successful, we had an evidence base, and it was an area that a lot of people weren't focusing on. And so what we did was we brought the right people together, and I'll talk about that. We continued to build our expertise and continued to really be intentional about harnessing the learnings. And then we worked across and within the whole system of child care to really think about impact and really work together on that. So what we first did in 2009 in partnership with the CDC, we worked to have the first conference where we brought together people in obesity prevention and people in early care and education. And so we were really breaking down some silos and getting two very distinct groups to start working together. And that then led to a steering committee that we've co-chaired with CDC since that time. And we have about 40 experts that we bring together on periodically to really work on obesity prevention in the space of child care. So we were really bringing together these two sectors to be a catalyst for change. And what we do in this, we talk about policy, research, and practice, and we talk about the key issues and how to spread and scale that nationally. So this is I'm just going to go through this quickly, just to give you a sense. You know, it was important to start locally to build that expertise. We started in child care facilities, but we knew we couldn't address the entire population by just one child care facility at a time. So then we started about how do we spread and scale in our state. So then we started working with the child care professional development training systems, because they, just like doctors, need to have trainings, and work to train the child care providers on healthy eating and physical activity. Again, it was a way to spread and scale. We did a number of different things there, and we took advantage of the Child Nutrition Act, the Child and Adult Care Food Program, and their training programs as well. And then we had a great opportunity for policy change. We worked with our child care licensing agency to have them have healthy eating and physical activity be a part of their licensing rules. So to be licensed in Delaware for both family child care and licensed child care, you have to meet standards relating to healthy eating and physical activity. So that was an opportunity where we could enact policy change that then would help support the practice change. And I mentioned already that we started working nationally on this because there was a void. We worked with the First Lady. We are both the creator and host of Let's Move Childcare, something we do in partnership with the First Lady. And we've continued to do work in this area, both in Delaware and nationally. And the thing I mentioned earlier, too, is working in we really thought about sustainability, and in all the places where we could embed healthy eating and physical activity as a part of the child care world. And this is a great slide that the CDC put together that kind of lists out all the different avenues in terms of trying to embed healthy eating and physical activity, anywhere from the licensing to technical assistance to early learning standards. So we were able to build expertise in this area, and I mentioned earlier we have this model that is evidence-based around using a learning collaborative by bringing together groups of child care centers to learn about changing their centers' policies and practices. So some of the examples of policies and practices that were changed, making more self-serve water available to children at all times, getting rid of the sugar-sweetened beverages, replacing the whole milk with 1% milk, and also creating policies where children have at least 60 minutes per day in childcare for active play. Those are the kinds of policies that were changed. We're really fortunate, and I want to acknowledge and thank the great work of the CDC to apply for and get the award to spread this collaborative method to 6 additional states. And this was using, as I mentioned earlier, these are opportunities that are available through the Affordable Care Act. This is through the Prevention and Public Health Funds. This is a 5-year program, 20 million, up to 20 million over 5 years. We launched the project in 2012, and the idea is to spread it to 6 states and to increase the number of child care facilities that are focused on and adopting healthy eating and physical activity and breastfeeding and screen time, and also by doing that to increase the growing numbers of children who are experiencing healthy eating and physical activity while in child care. So that's an example of being intentional about finding something that works at the local area and then spreading and scaling it. Ultimately, we hope to reach in this first year over close to 85,000 children in 6 states. And so we're spreading the work that we did to Arizona, Florida, Indiana, Kansas, Missouri, and New Jersey. So I also want to talk about another approach, and that is really working at the nexus of the clinical sector. We were fortunate to, again, through a competitive process, and again through the Affordable Care Act, to be awarded one of the CMMI Innovation Awards. In this particular case, we're working with and here we're looking at the individual first. We're looking at children who come to our primary care clinics with asthma. And what our goal is to reduce the asthma-related ED use and asthma-related hospitalization, not just for our patients, but for all the Medicaid patients in Delaware. So we really did take a population health approach to this. And we have other goals in this as well, but part of what we're doing is we're looking at the experiences of these individual children and looking at more than one, looking at groups of children and trying to see what is happening in the community and what are the policies and systems changes that are needed to support that child's health and development. And so one of our goals in this project is to enact policy and systems changes that affect at least 50,000 children. And this is a complicated diagram, but basically it was a really great exercise because it's really a logic model. It really looks at the primary drivers and identifies the secondary drivers, and it links it all up to the outcomes. And one of the things we've really learned in our work is that you have to start with the outcomes. You have to know what your outcomes are and then work backwards in terms of thinking about change. And this is a chart that really shows how we're starting with our own Nemours patients and actually in our own Nemours patients in just 3 sites. We're going to then expand that to our primary care centers throughout the state of Delaware. Then we're looking at children with asthma in 6 targeted zip codes. So ultimately, we're going to look at all children in those 6 targeted zip codes. That's why I call it the inside-out approach. We're doing this in 3 areas in the state. This is a little progress report on what we're doing, but the essence of our proposal is we have a family-centered medical home, and we're linking that directly to what's happening in the community. And we are creating a new disciplinary team to do that, of psychologists, of other health professionals, including, of course, clinicians. We also have an explicit role for what we call the navigator role, which is our community health worker role. That's the person that's going into the homes that I mentioned earlier and the communities of children with asthma to see what's going on in those areas that's impacting their asthma. So we have the navigator role, and then we are also establishing the integrator role, where we are looking at what we're finding from our own patients and others, and then thinking about what is the systems change that's needed to then improve the health and well-being of children with asthma in this case. The other things we're doing along the way is we're extending our own EMR to the school setting. So now the school and clinical data systems are linked so that a child, it's all about the kid, thinking about the kid at the center. So then the kid, then if the kid's in child care or in schools or in the clinical setting, you have the data and you know what's going on with that child. We have a rigorous monitoring process and very rigorous goals and objectives that we worked on with CMMI, And some early results show that we are, in fact, reducing our asthma visits to the ED, and we're also reducing our asthma-related admissions. And so when Dr. Shortell talked about putting a red X on the hospital, that's actually what we're doing. We're really trying to prevent hospitalizations and to prevent the use of ER. And this comes from an organization that is hospital-based. In addition, we're taking a lesson from what I mentioned earlier with childcare. We're really being deliberate about how do we harness learnings, and in fact, we're working with CMS, with the other awardees that are focused on population health. We have a little population health network, and we're working on harnessing the lessons learned and helping to inform things nationally, but we're also helping each other, for instance, with the integrator role, and what are the functions that are related to the integrator role. And also we're focusing on dissemination. I know my time's up. I just want to, just 2 more slides. One is really a story from the field. So something that our community health worker found out for this Hispanic family that has a 4-year-old that came to the office. We visited where he lived. He lives in a trailer. There's 15 candles lit under his sink. That's one of their ways of showing light, and this is the way they're living, and it really has an impact on their health. There's no medicine in the home, and even though they visited with the doctor 2 weeks previously, the medicines that were prescribed were never picked up. And the father doesn't think the child has an asthma problem. He thinks the child is overweight and lazy. The mother eventually brought out what she did have, and it was a box with 2 brand new spacers in sealed plastic wrapping. And here's another case of a mother who, again, we're trying to reduce going to the emergency room and reduce going, having hospital admissions. But the mother saying to the doctor, you've got to stop making me come, into the office during office hours because I can't keep missing work. So these are some of the realities that, that we're facing. I do want to spend a second on Medicaid, because one of the things we're exploring in all this is how can Medicaid help to sustain population health. And some of the things that we've now just written a paper on is there's a lot of myths about what you can use Medicaid funds for. And you actually can have Medicaid pay for non-traditional providers. You can have Medicaid pay for services in non-traditional settings. You can provide non-medical services. And there are a lot of myths in Medicaid, and some of the things that we're learning from all of this work is that people need to know what the successes are out there that people are, so that they can know these kinds of things and make the changes. Finally, I think we learned about the fact that we need to disseminate the lessons. There needs to be a collaboration between the public health and Medicaid leaders in particular. Medicaid is very complicated, and there needs to be intentionality around making sure that that public health and Medicaid leaders communicate and partner. One of our recommendations is that financing is needed from Medicaid to support integrators, and that when we're thinking about payment systems, we need to look over a longer period of time, because we need to give time for these prevention strategies to demonstrate the results and the return on investments. And finally, as I said before, that there needs to be clear pathways to help states achieve the long-term goals, and they need to know what those pathways are. And luckily, I think CMS is now doing a lot of work in the area of prevention and Medicaid, and they're starting to really focus in on what are the venues for states to do work in prevention. Thank you.
Very much, Debbie. Our next speaker is Genoveva Islas Hooker. Veva is the program director for the Central California Regional Obesity Prevention Program. Veva.